Hi, I'm Dr. Stuart Goldberg from the John Thor Cancer Center and Hackensack University Medical Center, and I'm here at ASCO 2014. I'm working with managingmds.com to provide you with an update on the treatment of this disorder. I'm sometimes asked when I have a new patient, what do I tell them? What's their prognosis and how do I pick between the treatments? Well, to help define prognosis, the International Prognostic Scoring System was developed in 1997. This simple system utilizes the number of lines of cytopenias, the percentage of blast forms, and the type of cytogenetic abnormalities to place patients into prognostic groupings. For example, the patient who's just anemic but does not have high blast percentage and has good or normal cytogenetics has a fairly good outcome. More recently, the IPSS scoring system has been revised, the so-called IPSS-R. This system makes some minor adjustments. The biggest change has been the introduction of stratification based on the degree of cytopenias. We all know that the patient who has a platelet count of 80 is low, but has a much better prognosis than the patient who has a platelet count of 2, where if they fall, they can bleed to death. So we now look at the degree of cytopenias. We've added some new cytogenetic risk factors, cytogenetic status factors, and we've also added an age correction. Once I do this scoring system on the patient, I can place patients into groups where they're fairly low risk or intermediate 1, or they're fairly high risk for progression of disease, the so-called intermediate 2 and high risk patients. If the patient has intermediate 2 or high risk, their survival is the major question. These patients may only live 1.5 years or 2 years with transfusional support. So for these patients, we typically think about the hypomethylating agents very quickly, since we do know that survival can be improved with these. The real question becomes the low-risk patients, the patient who's just anemic, the patient who just has thrombocytopenia, the patient who does not have a lot of blast forms. Here in these low-risk patients, questions of how do we treat them? And even the NCCN guidelines are a little bit vague here. If we have a patient who's just cytopenic but not that sick, we may want to observe them, or we may want to think about growth factors. But in the NCCN guidelines, it says if you have clinically significant cytopenias, that's when we start to think about treatment. And the treatment could take the form of lenalidomide. The patient has a 5q- abnormality and is principally transfusion dependent. Or we could move to the hypomethylating agents if the patient has severe cytopenias, such as neutropenia or thrombocytopenia. So the hardest patient is the low-risk patient on the IPSS scoring system who has sort of a moderate cytopenias, and that's where the NCCN guidelines are somewhat vague, and I think that we as doctors have to look at our patient and figure out what are we trying to accomplish. That's a little taste of how we treat MDS. For more information on this disease, check out managingmds.com. Thanks.